Hello everyone, my name is Hunter, and today we're going to discuss the Garden classification system for femoral neck fractures. Femoral neck fractures are serious injuries that can threaten the blood supply to the femoral head. In this video, we'll walk through the Garden classification, a simple four-stage system to describe these fractures and guide treatment decisions. Before we start, let's orient ourselves to the anatomy you'll see in the following x-rays. We can start by identifying the acetabulum of the pelvis in green, where the femur will insert via the femoral head in blue. Just below is the femoral neck, which is seen in pink, a narrow bridge of bone that transmit forces from the hip to the shaft. The greater trochanter in the light blue lies laterally as a prominent bony landmark, and the lesser trochanter in yellow sits medially. On AP views, you can look for the smooth cortical outline from the head along the superior and inferior neck and into the shaft. On lateral views, meanwhile, you'll see the neck profile and any changes in alignment or angulation. So now let's talk about the different Garden classifications, starting with type 1, which is an incomplete fracture. Valgus impacted. The fracture line doesn't traverse the full neck, and the head tilts slightly into valgus. On x-ray, it can be subtle, but if you look here in red, you'll see the fracture line. Harder to appreciate but present is a compressed inferior cortex and a minorly increased neck shaft angle. Because the bone end remains impacted, this is considered a stable fracture with low risk of disrupting the femoral head's blood supply. Stability here means you can preserve the patient's native hip. Cannulated screw fixation is the usual choice, especially in the physiologically elderly but still ambulatory patients. In this pattern, nailing is unnecessary and arthroplasty would be excessive. Next, we'll talk about type 2, a complete fracture, but more importantly, it's non-displaced. This fracture line extends all the way across the femoral neck, yet the cortical edges remain perfectly aligned. On the radiograph, you'll see a red highlighted fracture spanning the neck, but unlike in types 3 and 4, which we'll soon see, the cortical edges that remain in contact, as you can see via the femoral head in blue. Although alignment is preserved, the risk of vascular compromise is still present here. The goal is to keep the native joint. Cannulated screw fixation or multiple pinning is standard, and it's essential in younger patients to achieve a perfect anatomic reduction to avoid non-union or avascular necrosis. Next, we'll discuss the Garden type 3, which is a complete fracture with partial displacement. One cortex still makes contact, but the other shows a step off. On your x-ray, the fracture line is highlighted here in blue. By virtue of losing cortical contact, the neck shaft connection is misaligned, which is helpfully visualized by this red line. The instability comes with a high risk of vascular compromise, and the fixation strategy depends heavily on the patient's physiology. In younger patients, the priority is preservation of the femoral head. Open reduction with internal fixation and multiple screws or a dynamic hip screw can restore anatomy. In older patients, the risk of fixation failure is high, so hemiarthroplasty is often favored to allow early mobilization and reduce complications. Lastly, we'll discuss type 4, which is a fully displaced fracture. There's no cortical contact between the head and the shaft, and alignment is entirely lost. On the radiograph, you can see the fracture line in red. Then, two further red lines help to see the malorientation of the femoral neck relative to the femoral head, which is highlighted in blue. This injury almost always disrupts the medial femoral circumflex artery, meaning the femoral head's blood supply is gone. In elderly patients, internal fixation is rarely successful. Total hip arthroplasty or hemiarthroplasty is preferred. In younger patients, open reduction with internal fixation can be attempted if a perfect reduction is achievable, but even then, the prognosis is guarded. So in conclusion, and perhaps to simplify, Garden classifications type 1 and 2 are non-displaced, and the best strategy is generally to preserve the femoral head with screws or pins. Meanwhile, in Gardens type 3 and 4, which have displacement, younger patients may need fixation, while older patients need more aggressive measures, usually hemiarthroplasty or total hip replacement. Recognizing the Garden type guides not just your diagnosis, but also your fixation strategy, and that choice can make all the difference in patient outcomes. For more orthopedic imaging education, we hope you subscribe to Bone Mods. Thank you very much.